So in this presentation, we're talking through a few key concepts about heart physiology. We're going to cover some action potentials, ECG interpretation, types of myocardial infractions, autonomic effects, calcium handling, and the cardiac cycle. All right. First, we're going over ventricular action potential. So it starts with phase 0, which is a rapid depolarization. And this is where sodium channels open and sodium rushes into the cell, causing the membrane potential to shoot up. And then phase 1 is with a brief dip, and this comes with potassium briefly leaving the cell. And then phase 2 is called the plateau. And at this point, calcium comes through the L-type channels, and while potassium leaks out slowly, this calcium is coming through these channels. This balance is what's holding the membrane at no change. It's staying at that plateau. Then we go on to phase 3, and in phase 3 it's called the repolarization phase, and the calcium channels close, potassium flows out, and it returns to cell rest at the membrane potential about negative 90, 96 millivolts, closer to the potassium point. And then finally phase 4 is the resting phase. And this is where the potassium channels maintain a stable negative 90 millivolts. And if you look closer here, you can see the different types of channels. There are a few different types of potassium channels that open up to allow for the repolarization phase, and they have different names. They have the potassium slow delayed, potassium rapid delayed, and then potassium ultra rapid delayed. Okay, and now moving on to the phases of SA node action potential. Alright, so here we have a few less phases. We're looking at it. This is referred to as the heart's pacemaker, the SA node, and it has kind of a unique action potential. So at phase 4, this is a pacemaker potential. We have these things called funny sodium channels that slowly bring the voltage up to threshold. And the T-type calcium channels are also helping as well. They'll eventually open. And then when threshold is reached, phase 0 begins, and L-type calcium channels open. And this is when the calcium enters the cell, and the action potential occurs. And phase 3 is the repolarization of the cell. And this is where the potassium channels open up, the cell rests back down to about negative 60 millivolts for just like a split second, because it's going to be constantly going. So what's kind of unique about this action potential of the SA node, it doesn't really have a resting membrane potential. It hits that point and then it just starts depolarizing again because of those funny sodium channels. Moving on, we're going to talk about ECGs a little bit. And so looking at this ECG, we have a few different types of waves. So some key ones here are the P wave, which is the atrial depolarization. And then we have the QRS complex, a big peak there in between the P and the T wave. And that is a really large and fast point within this ECG. And it actually hides the atrial repolarization. And then the T wave shows ventricular repolarization. And then talking about STEMI versus NSTEMI. So this is referring more to kind of like heart attacks with the STEMI. A STEMI is a full blockage, which causes a full thickness heart attack, which means through the entire wall of part of the ventricle, it doesn't work there. And you'll see an ST elevation on your ECG. An NSTEMI is a partial blockage, and it affects just the inner part of the wall, and it's not as intense as a STEMI, and not as urgent, but still needs to be treated. This shows a little bit of ST depression, ST portion of the wave depression, or a T wave inversion. And both STEMIs and NSTEMIs will damage the heart, but STEMIs are much more severe. Okay. Now we're going to talk a little bit about autonomic nervous system effects. The nervous system plays a pretty big role in how strong and how quick or slow the heart will beat. So we have norepinephrine from the sympathetic nervous system will act on beta-1 receptors, and this will speed up heart rate, and we call that chronotropy. It strengthens each contraction, which we call inotropy, and then it also helps heart relax faster, and that's lusitropy. And this works by increasing calcium entry into the cell and also speeding up the calcium cycling. And then we have acetylcholine, and this is relating to the parasympathetic system, and it does the opposite. It slows the heart rate by opening potassium channels, which also reducing cyclic AMP in your SA node. And it doesn't really have an effect when it comes to contraction strength. So only the sympathetic nervous system has any effect on the strength of contractions. Parasympathetic only affects the heart rate. Alright, now a little bit about calcium-induced calcium release. So when we have L-type calcium channels open, calcium will enter the cell. This will trigger more calcium release from the sarcoplasmic reticulum. When this happens, calcium will bind to troponin, and this will let actin and myosin interact, causing the contractions very similar to skeletal muscle contractions. And then to relax, calcium is pumped back to the sarcoplasmic reticulum by the circupump, and then also will be pumped out of the cell by the NCX exchanger and the calcium ATPase. And that's something that's a little bit more unique within cardiac muscle compared to skeletal muscles, that they have a pump that actually pumps calcium out in exchange for sodium. Alright, and then phases of the cardiac cycle. And we're going to focus mostly on the left ventricle and left aorta. This starts with isovolumetric contraction. This is where the mitral valve closes, and we'd call this S1, or the first heart sound, which is the lub. And then when the pressure rises and the volume doesn't change yet, we call that lub, or S1. Then next we have ventricular ejection. This is where the aortic valve opens and blood flows out because of the high pressure of the ventricle. That's where it peaks on the graphs there. And then finally we have ventricular filling. This is where the mitral valve opens, blood flows in passively, and the atrium contracts at the end to top it off. So a key point there is that blood's going to flow in to the ventricle passively, but the atrium will just push a little extra blood in there to fill it up as much as possible. And then we have stroke volume, which is the difference between your end diastolic volume and end systolic volume, which normally is about 70 milliliters. of blood. Alright. I believe that is it. Thanks for listening if you did. And I hope you got something out of it. Thanks.